You're listening to The Dental Guys, episode 57. Occlusion does matter until it doesn't, with Dr. Gary DeWood of Spear Education. Have you ever wondered if articulators matter, and if so, when? Doesn't a virtual articulator have a place in dentistry, or are the analog articulators here to stay? An expert, Dr. Gary DeWood, who wrote his thesis on articulation, joins us to demystify our occlusal problems and help us figure out when occlusion does and doesn't matter. Dr. DeWood explains to us how airway issues in patients have turned his treatment planning and conversation with patients upside down from what he did just a few years ago. Don't take it from us. Take it from a man who has 350 articulators this week on The Dental Guys.
This episode of The Dental Guys is brought to you by the Dental Crafters Network, your implant restorative connection. From surgical planning to patient-specific guides, quality implants, and final restorations, the Dental Crafters Network provides one relationship with infinite possibilities. Call 1-800-472-8302 today. That's 1-800-472-8302.
And welcome to this week's episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy.
John, an exciting day for us is coming at the Voices of Dentistry conference at the end of January. And if you're listening to this right now, it's around Christmas time. So Merry Christmas to you and your family. Hope you're enjoying this. But next month, we're going to be in Scottsdale, Arizona for the Voices of Dentistry conference. We're going to be there speaking. We're going to talk about a topic that I think that is pretty hot, and we're excited about that. Not only that, is we're going to be recording some pretty awesome podcasts. I know that we're going to have some pretty special speakers there available for us to pick their brains to, and John, some surprises that we may reveal there.
There's going to be some big stuff kind of revealed there at that show, so definitely stay tuned to that. We're going to be doing some live streaming from that, so you may be able to get that actually the day of the conference rather than having to wait a few weeks for us to release that. So we'll be giving you more information, but we just want to tell you, hey, if you have not signed up, this is probably your last chance to do so, to get hotel, flights, and everything, because we know it may already be filled up by now. But if it hasn't, definitely get signed up. Go to voicesofdentistry.net, check it out, sign up, get there. We want to see you there. And speaking of Scottsdale, it's the perfect segue. Speaking of Scottsdale, there is a place,
it's Dreamland,
a mythical place in Scottsdale that we have spent some time learning at, and we want to welcome today Dr. Gary DeWood to our show, a very, very special guest. Dr. DeWood, thank you for being on the show today.
It's my pleasure. Thanks for having me.
Yeah, we first learned about, this name has been around a while, obviously, for any of you.
What are you saying, John? No way.
I'm saying that Gary is a young man,
the gray hair is
made
showing.
He's made an impact in his young years. Yeah, it's amazing.
Right.
But he's Dr. DeWood has been involved in dentistry and dental education for many years, doing various things, and pretty much anybody that has, I think, been around dental education has probably run across his name, or people that have been touched or influenced by him. And we were first influenced by Dr. DeWood when we went out to start the Spear Education Continuum with facially generated treatment planning and occlusion. And a lot of what we'll be talking about on the show comes from some of the things that were opened up to us through those courses and subsequent courses we've taken. Dr. DeWood, if you would just tell us a little bit about sort of your dental journey for those who might not know you. What are some of the kind of the highlights of that, and where are you now? What are some of your interests now there at Spear?
Well, thanks for asking. I started out practicing in a small community in Ohio. My wife and I graduated from dental school together, and we set up a practice in a little village named Pemberville, 1,200 people. Nice little burg. It was a great life, and the kids loved the place. But after about 22 years there, Cheryl decided that she wanted to specialize, so she went back to ortho school. And we didn't anticipate coming back to Pemberville, so we sold the practice. And at that time, I thought I'd be moving to Memphis, Tennessee, which is actually where Cheryl did her ortho training.
Okay.
And I wound up instead on Key Biscayne, Florida, as the as the clinical director at the Pankey Institute, and spent 5 years down there teaching. Decided at that point that I didn't really think South Florida was where I wanted to spend the rest of my life. And so Cheryl and I decided to go do something different. I've known Frank for many, many years and ran into him. Actually, we had dinner and I was on my way to speak to some people in California. And when I started telling him what I was doing, he asked me to please come to Seattle, which I did. And after about 1.5 years, we moved the whole business here and founded Spear Education. So that's kind of the trail that got me here.
Yeah, and so you had been involved to get to the point of being the clinical director at Pankey. I'm sure that meant that you had been involved.
I had been involved on the visiting faculty there for
Yes.
for many years.
Yes, and
Yep.
so really your journey, it sounds like, started out similar to a lot of us who wanted a little bit more, who wanted to know more, and you just kind of just always kept wanting to know more, and it took you all the way to the place you are now. And what are the things that it sounds like, the courses you teach at Spear mainly are some of those foundational courses. So tell us a little bit about what you teach there at Spear.
Well, actually, when we founded the company, I was in every workshop. Frank would come here and do seminars, and I was doing all the workshops with him. It was just the two of us. So as we developed workshops and added faculty, I had parts in all of those, with some exceptions in about the last 4 or 5 years because there were just too many of them. My favorites are the foundational ones, as you said. I like facially generated treatment planning and occlusion. They're my two favorite courses. Although restorative design is right up there. That's our prep course. I really loved that course. Today, I have kind of backed away from some of that active workshop teaching. I'm teaching in facially generated treatment planning. I'm teaching some in occlusion, although I backed away from bits of that because I'm spending more time with our consulting business, which is called Spear Practice Solutions. And for me, that's always been an important, I've always believed that the teaching stuff is excellent and people get stuff and go home. But if you can help them integrate it when they get home,
There we go.
you've really added a power to it that is not there if you just teach people things. So I was really happy when we decided to do that, and we've been doing it about 1 year now, and it's a learning curve always, but it's
Right.
it's fun, and I'm getting a good chance to spend a lot of time with a lot of fun people.
So
Well,
you
I
feel like
just have to say before we get into the meat of the show that I think it will, and I know you probably heard this same thing before, but I think surprised when we came to facially generated treatment planning, as many are, as to what the first day opening session was about.
right.
I did not expect it to go how it did, and that was a very good thing. It was you teach, and I don't know if this has always been the way you've done it, but you spend a lot of time on that first session not talking about dentistry per se, but talking about what is it all about? Why are you here? What do you expect? What is this going to do for you? Because in the end, you have to know where you want to go. When is enough enough? What is important in your life? Where is this taking you? And even talking a little bit about the rule of 72 and how you think about your retirement and what does this mean? And I think that Wes and I came out of that, we were sort of blown away. It really got, because it centers you back on, again, what is this about for you? And that's different for every person that comes to that course.
One of my favorite things that I do in that course is I pop up the word success, and I say, I have a problem. I'd love to help you all get this, but I have no way to define it for you.
That's awesome.
Not sure what it means for you. So we'll talk about the dentistry part, but there's way more than that involved.
The clinical seems like it's, and you don't want to say it is easy, but it's hard, but you can teach methodical ways to go about treating occlusion and have a decision tree, but to teach you implementation takes a true mentor and somebody to put their arm around you. And it sounds like Spear Education's kind of taken that step into this practice. What did you call it?
We're hoping. Spear Practice Solutions.
Spear Practice Solutions.
Yeah,
I got
hoping.
to see that when we were out. I took my associate to his first ever
Cool.
Spear seminar up in DC when you guys brought the show out there a couple of months ago,
Right.
and they had, of course, the Practice Solutions booth set up and got to see what's going on. It's very interesting to see how all the metrics are able to be remotely mined in a way, so that this information can be continuously updated. It almost was like I don't know, logging into your your investment portfolio or whatever it is. You could see immediately in
Well, that's
real
what we
time.
hope. Yeah, we hope it's like that.
Yeah, and it was like like it's like seeing how the Dow's doing. Instead, it's seeing how your practice is doing, a live update. So very impressive. So this course,
John,
this show today,
this course,
this
show.
Yeah, we do want to geek out because we love to talk about really the nuts and bolts. And when we came away from some of the discussion you had about these topics that we're going to get into, it really we only, I feel like, scratched the surface of some of the time you've spent with articulators.
Well, articulators have always fascinated me. My master's thesis was on articulation. And the whole idea of trying to mimic what a person can do mechanically, I always thought was a really interesting thing. And today, and I know we'll probably get to this a little bit today, we can also talk about mimicking it virtually, because I think it's almost there. I actually have great hope that the day's going to come when I'm going to be able to say before I'm done that I get to do a case that I didn't have to put it on a mechanical articulator. I think that could happen.
Well, Wes, I'll let you kick it off with the questions here.
So the thing that before we, the show is interesting. The title is interesting, but the reason why we ask Dr. DeWood on the show for this is because of the fact of his passion for articulators. In fact, I think you mentioned that you have a quest to have almost every articulator that was ever invented or ever made. And I think either behind you or in that cabinet there or somewhere in your office, you talked about a place. Do you have a place where you have these articulators stacked?
I do. There is a cabinet in this room that has a lot of articulators in it. And then I also have kind of a storage facility where I keep
That's what I remember.
Dozens
How many
more.
are we talking
There's
about?
a lot of them.
How many? I mean, if you had to estimate, how many would you say?
Oh, probably 350 articulators.
But
I have a lot of duplicates. So you know what
question-
happens? People send them to me. So
That's awesome.
which is kind of fun.
So you're not out there eBaying late at night bidding on
No.
articulators.
No, I'm not an articulator hoarder. I'm not doing that.
It's a
the
legitimate.
first step is admitting you have a problem.
legitimate collection.
I think so. Yeah, and it's fun.
That's awesome.
It's a kind of a history of trying to understand, which I think is fun. That's a neat history.
When you understand where you've been, it sometimes helps you understand where we're going, and maybe studying those things has helped you. And I think it has, obviously, because you're an expert and wrote a thesis statement on it. But the question we're going to ask the expert today for our show is, do articulators matter? And we prep crowns each and every day. The average dentist preps 20 crowns a month on average.
Okay.
And some people use, all kinds of different types of articulators. I mean, everything from plastic to really no articulation altogether. I know John and I are digital scanners, and we get back modelless, crowns that we're seating, and for some reason that works too. And you mentioned that virtual articulation is almost there, and in some respects it is for single unit therapy. But John, in a day-to-day dentistry situation like this, when should we say that hinge articulators are good enough versus adjustable articulators? Is the classic hinge good enough for single unit dentistry, or how much dentistry can we do on a hinge, Dr. DeWood?
So what I would say is it's going to depend on the references that you have available. So let me use because you brought it up. You guys both do scanning and do CAD/CAM units in your offices. Okay, and I'm going to argue that you are using an articulator. It is a hinge articulator. Okay, well, it depends. Today, you actually with a CEREC could do even more than that, depending on how much you want to get into the settings. But generally, I'm going to argue that what you probably do is you scan your prep, you scan the opposing, you take a buccal bite scan. The buccal bite scan is with teeth fully intercuspated, right?
That's right.
Okay, we call those triple trays. I'm serious.
True.
You have done a triple tray impression where you have one place where it is highly accurate. That place is where the teeth hit each other. That's a highly accurate rendering. Triple trays are wonderful tools when you have enough other references to be able to create forms that will clear in movements away from that fully intercuspated position. But very often, I mean, for me, triple trays were a commonly used tool when I was doing partial coverage onlays, let's say, that included premolars and first molars, but not second molars. Because the second molar is going to give me a guide about what form I need to clear in all of the movements. So it's an interesting question when you say, are articulators necessary? Yes, if you need them. I know, I know someone. Actually, he's a famous guy. His name, not everybody would know him anymore because he's been gone for a long time. But his name was Henry Tanner, and he was a member of the Restorative Academy, and he did a program for the Restorative Academy where he showed a patient that he restored the whole mouth without ever articulating it. He did it all. He had to take impressions because he had to do castings. It was all gold castings. But he basically just used the patient as an articulator with wax in there and had them moving around, and then he created clearances. So the articulator somehow you need. I'm going to argue yes, okay? And even if you think you're not using one, you are, because you're using an articulator in your machine when you take the triple tray bite. Where that is not accurate is in movements away, which is why when you have multiple teeth further to the back, it becomes more useful to have some device that allows you to mimic what that person can do when you're forming teeth or when you're evaluating what you might change in an occlusion. So let me use an example for this. If I set up my articulator to mimic what you do, it means in my world I'm going to set condylar inclination. Okay, the condylar inclination on an articulator mimics the angle of the eminence. And if I have a patient who has back teeth that contact each other, it's a setting I would like to put on that articulator if I'm going to change their posterior occlusion, because that's a person who in the end is probably going to have some near misses. An articulator just became incredibly useful to me because I can now mimic that. And as I change it, I can see what clearances I've created. Let me create another scenario though. What if I have a same patient, I'm going to change things, but their back teeth don't touch? So when you ask the patient to move, bite down, and then move away from that position, their back teeth come apart incredibly quickly. Nothing touches in the back. I'm going to argue I probably don't need much of an articulator to figure out everything I need to know for that occlusion, okay? And while you were here, one of the things I said, and I'm sure I said it because I try to be reasonably dogmatic so that people can come back later and ask other questions, is that why would you not use the articulator in all the cases where you're doing lots of dentistry? Because even if you don't need it, it becomes an excellent reference. Okay, and then people say, well, yeah, but this, and this. And I say, you're right. That means you have observed enough and learned enough to know when you don't have to have that thing to tell you what you need to know. So for me, the best thing about an articulator is that it sets a reference, allows me to change things on some casts, and have a really good idea what will happen when I get to the mouth. I mean, that to me is the primary use of an articulator.
So the challenge then is to know when you need to when it's important and when it's not. And it sounds to me like, again, if you start taking courses like we have taken and you start thinking through again what what are the back teeth doing when the jaw moves, you start to see cases where it may be you could really miss things, you could really miss things, and other cases where, like you say, but if you don't kind of think through that, then you really don't know. You might just be frustrated. Why do some crowns take me 30 minutes to adjust, and some crowns take me no time to adjust?
So I'm going to argue this. You guys both know ahead of time, when you look at a case, you have an idea if occlusion is going to be an issue.
Mm-hmm.
So what you've done is you have enough experience now. You learned some things about it to help you identify the times when it's going to be something you have to really think about. But if you didn't take the time up front to say, hey, this is important, it would be impossible for you to recognize the times when it wasn't as important. And to me, that's why learning to use an articulator is one of those skills that is priceless, because it will allow you to make decisions. It's sort of like when we talk about stuff, what we talk about often is the problems. The stuff that, I'll use an example. The patient who has a lot of wear on second and first molars, has no wear on anterior teeth. You ask them to bite their teeth together and they hit all of their teeth. Why are their back teeth worn more than their front teeth? If they can hit all of their teeth when they bite, that doesn't make sense. So it tells me they must have an anterior open bite sometime. That's a person who can seat their joints, go back and hit their back teeth. If I'm messing with that patient and I'm going to change a bunch of teeth, I want to know what they can do.
That's right.
Right.
I'm putting that case on an articulator.
And that really, I think, messed with us the more we understood this from the course. Because, again, it's the classic, and this has happened to everyone, where it's that second molar that you do prepare, and all of a sudden you prepare 1.5 millimeters, and the temporary is made, and the assistant says, yeah, there's a hole in the temp, and you go, no way, I know I reduced that, and no, you didn't. There's a hole in the temp, and again, for a new dentist coming out of school, when I would see that happen, I didn't put it together.
No.
And now I do. Now I understand. Cool. Now I get.
That's what set me on this path. Was that exact kind of a thing? I just said I got to figure out what's going on.
Yeah, from a day-to-day single tooth dentistry situation, even it's a world that it opens up to you, not only for your full arch cases, but just for these. Just understanding what's going on and being able to relate this to the patient and why things are happening, why we're fracturing second molars, and all these other things that come into play. So knowing that, so I think we've kind of established a little bit of a groundwork here, that you always need some type of articulator, even if it's the patient, and you learn over time how to judge that. But
actually, the patient is the perfect articulator. Unfortunately, they leave.
Right.
That's true.
Sometimes hard to get them to do what you want them to do too. And if
that's true.
So with the storage unit and the 350 odd articulators that you have, what of course often comes up, I think, and this especially in the labs, at least as we talk with lab technicians.
This is a big lab question.
Is they want to know, is there a difference? I mean, and not just, they know there's a difference between articulators. I think everyone knows there are differences, but that's the simplistic question. But what should we look for in a semi-adjustable articulator when making a decision about purchasing a semi-adjustable articulator?
Yes. So I would say this. First of all, any of the modern articulators with magnetic mounts are absolutely excellent pieces of equipment. Now, they vary in the features. And so what I tell people when they say, what should I buy? I say, well, what do you like? How do you like to use the articulator? Well, I don't know. I said, go play with some. I'll give you some examples. Some of them you can lock and unlock and they come completely apart. I happen to like that. So for me, that just ruled out some articulators that make it difficult for me to unlock it and leave it completely free. Some people don't like that specifically. Great. Any of the ones that have a magnetic mount today, that are semi-adjustable, you can use with a high degree of precision. And so I think it becomes a matter of what do you like. Now, what is the minimum you have to be able to adjust? I'm going to argue condylar inclination. For me, that's kind of if you're going to have an articulator, have one that has an adjustable condylar inclination. Now, even one with a fixed condylar inclination, you might be able to use. The Dinar Combi is an example of one that is fixed, but you can change the angle that it's fixed at. So you could go in, and once you mounted things, you could have this little tool where you could measure and get the closest angle. So you could still go in and mimic that. I think somehow that needs to be adjusted because of the need to see what happens on back teeth. And I want to be able to see what happens as back teeth separate from each other. So having said that, what I would say is that beyond that, it becomes a matter of what do you really want to do with your articulator? Okay, if you want to adjust the immediate side shift, then you need more adjustment potential up in the condyles. If you want to adjust progressive side shift, again, you need more adjustment potential up in those condyles. All of those things are additional things. There's lots of argument about what good they do or whether they're even worth doing. And I would argue that in almost all joints that are healthy, if you can adjust condylar inclination, you probably have everything you need to understand what's happening for that occlusion on an articulator, on a set of mounted casts. If you have unhealthy joints, now more settings can become very helpful. Right. Because if discs are out and I can do immediate side shift, I would want to capture that because that means a person can do that on their teeth. I'd love to capture that movement. Now, the good news is there's a very small percentage of people where that becomes even something that's possible. So for me, you know, the one that you have to think about is any of the ones that are magnetically mounted models, and then any one that lets you minimally adjust condylar inclination.
And for some of our young viewers out there, you think, well, why would you want that in an office, a magnetic articulator? From a laboratory standpoint, I can remember the days, I graduated school in 2003, and we didn't have at the time, at least I didn't know of any, you had magnetic plates were just now coming on the scene, and I remember having my old classic Hanow articulator, and it was like, mounting rings that weren't magnetic. And so when we ended up shipping articulators back and forth between the dental lab and myself, and that in itself, the shipping alone, you know how many articulators were damaged in my practice? Lots. A lot. And so the idea now from a standpoint is we only have to send the models because they have magnetic mounting rings, and what you see in the laboratory or what the lab technician sees in the laboratory, you receive it in your office and you snap right onto your articulator, set that condylar inclination for this particular articulator. That's the simplest movement we're talking about adjusting for these cases. And it's exactly it's precision, which is repeatability, which is what a laboratory and a dentist need to have when communicating with one another. So I think the next question is like maybe we can make a little more granular for our listeners in what types of cases, because it's a small percentage, maybe not a small percentage, should we always use a semi-adjustable articulator?
So I'm going to argue that if you are restoring a lot of posterior teeth, and I'll let you define what a lot is. I mean, for me, if you're restoring 3 teeth in an arch, what percentage of the occlusion have you just altered?
Man.
A lot.
A lot.
So I would tend to think if I'm doing a bunch of posterior teeth, I'm mounting that on an articulator so that I can see what's going to happen. If I'm restoring 1 tooth and the other teeth are right where I want them to be and I don't anticipate changing them, then I don't know that I need an adjustable articulator. I really don't need that. I can visualize what's going to happen. I can look at other teeth. They'll give me form. They'll show me things. And a good technician can tell by looking at the teeth behind the tooth you're treating what kinds of angles they need to be able to clear, even if they can't mimic them. It will be incredibly close to that. In fact, that's one of the ways that the softwares are evolving such good designs. I don't know how long you've been doing your CAD/CAM stuff, but I go way back. I actually had a Cerac 1.
Oh, wow.
It didn't have burrs. It had a little cutting wheel. It was awful. It was the biggest piece of junk ever put out. It was terrible. It didn't work. But I've always believed in the theory of that. As that gets better and better, you have more and more information. And today, I mean, when I scan something, pretty much the proposal I get, remember back in the day, even as they got better and better, you always had to go in and tweak the designs.
Right.
I almost never tweak the design. I mean, you get the design,
amazing.
you might change some of the form because you want to close an embrasure a little or something, but most of the time I don't change anything on the occlusal. I mean, they work. It's incredibly well designed. That's because they have all of that kind of data that they use to figure out what that should look like. Okay, and I know that you know this. The fewer teeth you have to scan for it to look at, the poorer the design you get for that tooth.
Right.
Well, that same thing was knowledge that was based in technicians and dentists' heads. You'd look at the arch and you'd have an idea what you should make it look like.
Well,
So
I
the
think we
more
just
teeth that are gone, yeah, go ahead.
Well, I was going to say the most recent article that we read from JADA that talked about impression, one of the main problems that they saw in the impressions, one of the top listed problems, it was a high percentage. They didn't include enough teeth.
Not enough
for
other
even
teeth.
this- yeah.
Exactly.
Yeah. Yeah. So
Yeah, and we've already talked about that study. We don't want to dive into that.
go
So, and then I will add
Cold.
this on. I think that if, and this has just become for me kind of a pet peeve, and I don't think that you have to do it, because I know people who do without it and who do okay. But if I'm restoring a second molar, I'm going to put the case on an articulator, just because I have had issues develop. Those are the ones that gave me the most trouble. And then if I have a case where I have decided that I'm going to treat that case at MIP, even though they have a shift, you know, pretty often all of my study stuff is going to get done on an articulator. My wax up's going to be done on an articulator. Now, when it goes to the lab, I'm not going to mount it with the shift. I'm going to mount it at MIP because that's where I'm working from. But all of my planning, I need my articulator to figure all that stuff out.
Yes.
So that because I have to know what the patient can do. And for me, that's when an articulator becomes appropriate and important, when I need to mimic what a patient can do. Okay. Once I get beyond that, I don't know that it just is. It might be useful and fun to use, but do you need it? I don't know.
So I think this is sounds like maybe a simplistic question, but why is it that you think doctors don't use semi-adjustable articulators a lot of the time?
Because they have never been really trained in why they were doing it.
that's exactly right.
I mean, when you were in school, they just kind of said, "Here, do this,"
Yeah.
and it wasn't really clear why. Well, let me ask it another way. Even on on dentures, if you were trained to do dentures with lingualized occlusion, where you had to put a cusp in a receiving area and maintain contact in movement, you probably were taught to put that on an articulator because you had to be able to slide the thing around on each other.
That's right.
But if you were doing flat teeth, there were a lot of people who were taught, just take a bite, it doesn't matter. It's going to be right at the occlusion. Okay, that's correct.
Yeah.
It's the movements are the things that are important on the articulator. Okay, if all you need is where things hit, then any little kind of a hinge thing will work. Anything that I can open so I can do something to teeth will work. Yeah. So for me, as soon as you need to know more about what's going to happen as that patient moves, an articulator becomes a valuable tool.
And it seems like, and I think, Kevin Queeshan, we had him on the show before, mentioned, just a lack of teaching with intention, and I know you've mentioned the same thing, that there's not oftentimes, when you're taught about articulation in school, like you say, it's just, this is what we do, and there's not really ever a time where we say, well, let's understand why we're doing it and then ask you the question, should we do this? And I think that is not being done.
So I'm gonna make a comment about that because I do believe this. Doing that in dental school wouldn't matter because most of us didn't care about why. Just tell me what I have to do to be done.
Wow. You're right.
And I don't mean that as a slam on anybody. It's you're trying just to survive. I just want to know what I have to do. And I want to do it well enough that you'll smile at me and say, good. And the why can come later. And for some people, the why never comes because they get out and just do
really
stuff.
Hard for me, man. Even in dental school, just shut up and listen, right?
Yeah,
but
you want to stay under the radar is your main goal, right?
The thing was, a lot of times, and again, this is not, I don't want to slam dental education.
Yeah.
But it can be hard if you're trying to teach someone something and you really want them to understand it, and they just say, just tell me what I have to do.
Right.
And I think after a while, you realize
almost
that the
have to.
best thing you can do for them is that. Just tell them what to do, and then hope they come back and ask you some questions. And then a few people will get interested and will say, so why are we doing this? But they'll usually ask you. And I think the reason that more people don't use articulators is that when a lot of people got out, they realized, hey, I'm not doing that. I'm just going to do it like this. And they got somewhere, and somebody even might have told them that. I had a person that I met right out of dental school. Actually, I started buying articulators from graduating dental students, because back then you had to buy your stuff. All my first articulators that were the ones I bought from graduating dental students. They're done, and I would go to the school, and I would put a thing on the board, and I say, well, buy articulators. And they would, you can have it. I mean, some of it's like, I said, no, I want to give you money for it, because you're going to want to buy one later, maybe.
I bought mine from the endodontists that were going into
okay,
endo specialties.
Well, there you go. and now I think most people rent equipment. They don't. Most people in their kits now, you don't get to keep that stuff. But back then, you kept all that stuff. And I found that the people who learned to use an articulator probably had something happen early on in their career that made them question how the bite was working and want to understand it better.
Right.
Yes.
And so all of a sudden you say, geez, I remember this from school. You know what? I have the face bow. I'm going to go try and get this. The reason people don't use it is that because it honestly is not a necessity in much of the world for what you do. When you understand it, that's easy because you'll pull it out. You just say, well, it works without it. And the bottom line is, it often does. Even the case we talked about where somebody can shift back, a lot of time when you restore that patient, they do okay, which is good. I'm glad for that. The nightmares are the ones that don't. And those are the ones that if you have one of those, I think it stimulates your interest in wanting to understand more, mostly because I don't want to make that happen again because it didn't feel good.
Right. That's a bad day. Well, I think that gets us, a good understanding of that many of us are. The question is, do you go back and ask the questions afterward, like you say? I mean, you're trying to just get through in dental school, and we hope that the people that are listening to this show, that's the next level for them. Is like you say, they have those bad days. They want to go back and ask the questions. And I think one of the questions that came up from the occlusion course specifically, and a lot of that is kind of continued on for Wes and I as we've kind of dived into some of the other courses out there at Spear. We talked a lot in that course about what is making people wear their teeth.
Yeah.
And what is the cause of posterior wear, anterior wear? What are the different types and classifications of wear? And as we talked about that, you paid very close homage to the fact that there is an evolving area in dentistry that has been evolving over the last 10, 15 years especially. Yep. on how sleep affects bruxism.
Well, let's call it airway. I've taken sleep out of my lexicon. Sleep is one aspect of an airway issue, and it's often the canary in the coal mine. It helps us ask questions that help a patient understand maybe they have an airway issue, but let's call it airway.
Very good, very good. So I completely agree.
Okay.
So we, as I was looking back to try to ask this question with some knowledge coming into this, Wes and I have taken the courses at Spear that dive into how dental sleep medicine, airway, sleep disordered breathing can affect this, and it really challenged us, of course, to go back and look at our occlusion course and to say, so. What's, because we talked to some faculty there that say, I won't make a splint unless I have a home sleep test, and so we're going, okay, well, how much of this is connected? So, we start doing a literature search as we kind of geek out about things. And so we go back and this is the way I roll. And so I go to PubMed and we start reading some literature. So I just want to just very, very quickly just say, I pulled up, I got about 10 studies sitting here. And, here's a study in 2006, pilot study from a pneumology journal. This pilot study shows that sleep bruxism is a very common phenomenon in a group of mild sleep apnea patients, probably being secondary to it in the majority of cases. Then the next study, jumping ahead a couple of years, we found that patients with obstructive sleep apneas have a high risk of sleep bruxism. And this relationship suggests that improvement in OSA may prevent exacerbations of sleep bruxism. Another journal that same exact year, there is not sufficient scientific evidence either to confirm or discredit the association between sleep bruxism and sleep disordered breathing. And then jumping ahead to a really recent article from the Journal of Oral Rehabilitation, which was a systematic review or so-called systematic review. It can be concluded that there are not enough scientific data to define a clear causative link between OSA and sleep bruxism. However, they appear to share common clinical features. Further studies should focus on this. So there's a very confusing literature out there that is really, to me, I'm trying to cut through this. I'm trying to understand this better because I want to know with these patients how much, we're talking about all this, how much does it matter? How do we know? Do we know? Where are we with this?
So the first thing I'd love to say is this. The literature has not gotten less confusing over the years. It's always been confusing. I learned early on that if I want to prove one side or the other, I probably can pull up plenty of studies that would help me show that.
Good point.
So having said that, one of the things you learn to do when you do a master's degree is to read the literature because you have to. And so what I have learned, at least in doing that, is that one of the first things I do is I try to figure out, how many people were in the study and all that stuff. So let's say those are all good studies because I'm going to argue you can get the same results. I'm going to give you my personal impression based on what I think right now. And it's brought me to this realization that you might have heard me share. If you do something long enough, you have to be ready for everything you know to be wrong. Because that's okay. It's okay. If you're a scientist, it's okay if you're wrong. Okay, so let's leave it open to speculation, but let's go with what we see today. So early on, my belief was that occlusal issues were caused by interactions of teeth that caused people to go in and beat their teeth up, because it's what we all believed. There were connections made. We went in and we looked around and we said, wow, this person has a big interference in the back, and then they come forward and look right where all the wear starts right there. So that must be part of what's happening here. In some cases, when we would treat that so they didn't have it, they stopped bruxing. But in many of those cases, we had altered other things besides just that. And so the variables that were involved were huge. So let me tell you what I believe today based on everything I can hear, read, and try to figure out by hanging around with some really smart people. Occlusion matters, except when it doesn't matter. I know, isn't that awful? So let me tell you how I kind of would look at that.
Write that down, put it on the wall.
Okay.
Yeah. Maybe the new show title. We'll see.
I think it does.
Occlusion matters because people still have to put their teeth together and function. I believe today that the cause of a lot of bruxism, what I thought caused people to brux on their teeth and destroy their teeth, is an airway issue rather than a mechanical issue. And the reason I believe that is there was one study that you didn't quote, and I'm blanking on the name, it begins with an O, where they took people who were sleep bruxers. And all of them, they separated all the ones who bruxed. And the number that I have heard in the past is that about 40% of people who have apneic events brux as part of the apnea.
Yes.
So they took only people out of that 40%, and they put all of them on a CPAP. 100% of them stopped bruxing episodes. There were no bruxing episodes that occurred. The other interesting thing I heard you say, which I really loved, you said that in mild to moderate apnea patients, they found higher levels. Well, one of the things that I'm coming to understand as I see this is I think that people who are apneic just have given up. Before that, the reason the bruxing is happening is that you're trying to breathe. And today I believe that it doesn't happen, it's not a sleep thing, it's an all the time thing. People are bruxing, are getting their teeth in a different position and putting them together to help themselves breathe. There's a guy up in Montreal, his name is Gilles Levine, and Gilles has written a lot of stuff, and he flipped my world around when he published a book on bruxism, where he said in all of their studies what they're finding is 80% of bruxism has happened during the day, 20% at night, and most of the most destructive patterns are during the day, not at night. That's what he uncovered, all this kind of stuff. And I remember at the time thinking, wow, so then what is my appliance really doing? Well, this is what I've come to believe also, though. There are some people who also do brux for mechanical reasons. They go in because something doesn't fit and they're bruxing. That's their stimulus to brux. Now, I believe there are way less of those people than I used to think. Way less of them. One of the things that we did when Jeff Rouse joined us, he asked us to bring some cases, and we got together and we looked at cases. And cases, severe wear cases, that had worked and that had failed. And if you treated enough wear patients, I promise you, you have a bank of people that it didn't work on. I mean, they destroyed everything. My favorite patient, you've heard me, is Pat Smith. I restored her 5 times. She destroyed everything I could possibly think of to put in there, eventually breaking them off and having teeth come out. And at the end, she had 4 teeth left in her mouth with ERA attachments. Today, they would be locators and dentures over those. Yeah. And actually, the part of the story that I found most interesting is that when I left practice in Pemberville, she gave me this beautiful glass art sculpture, and it had been engraved on it was, "I can never thank you enough for helping me keep my teeth." I remember thinking, what, have you looked in your mouth lately? I mean, right. But here was the interesting, she was my partner in it. In hindsight, I have no doubt that she could not breathe. She could not breathe. And everything I know that I've learned is telling me that. Now, I can't go test it out because she's no longer with us. But having said that, sometimes it worked. And one of the things that we uncovered as being a common theme was when we opened vertical dimensions substantially, we were seeing more people who weren't destroying things as quickly. Isn't that interesting? Yep. Well, all we did was make more room. Maybe we were able to have them give more space for an airway. Now, I don't know that, and I can't prove that for most of what I did. I bring it up to say that what I believe today is that understanding how people are managing their airway is a vital part of what you're going to do if you're going to treat wear patients. And today you can do some things because we found that sometimes appliances help. What do appliances do? They open the vertical dimension. For some patients, they let them come down and forward, especially if they were a TMD patient. Because for those patients, I would not be telling them where to go to. I usually wouldn't be seating condyles. I would say, where are you most comfortable? And we'd start there. And so you'd find a place where they felt comfortable. And years ago, when I discovered that, I used to say, well, those are people, for some reason, there must be something wrong, because if I put them at centric relation, they're not happy. They're not comfortable. They're not sleeping well. They're not functioning well. If I let them come down and forward, all of a sudden they're comfortable. Wow, maybe those LVI guys had something going on.
That's what I was getting ready to say.
And that was the thing, that exact comment right there. Wes and I had the exact kind of aha moment. We said, oh no, this whole time, all of this, we said, oh, you're tensing patients, you're opening vertical, these dramatically large crowns, and surely that does not work. And now we went, oh my
But it
goodness.
worked for some people.
It worked.
It worked for them.
People got better.
Exactly.
And the reason they got better is because they now had an airway.
Which is why I went to LVI and took the classes, because I wanted to understand what the thought process was, because I saw patients that it worked. And what I realized was, later on, I put some of this together in my head, I found that place for a lot of patients with appliances. Because all of a sudden, it's where they got comfortable and were telling me, this is great, I'm sleeping the best I've slept in ages. I mean, now knowing what we have learned today, I keep thinking, boy, I got lucky and found a place.
Yeah.
Right?
Yeah.
Wow.
So today what I would say is this. If you're going to be a restorative dentist, and wear patients are one of the kinds of people you'd like to treat, and if you're going to be a restorative dentist, you're going to see them, you have to begin to understand a way to evaluate how is this person's airway working. And I think it's a wonderful thing for us to do. It's sort of like taking blood pressures. Just because we don't treat blood pressure doesn't mean we don't monitor it for our patients. I had my teeth cleaned today. My hygienist took my blood pressure. You know, that's what happens. That's a wonderful thing we can do. Even if you've chosen not to do something around breathing issues, understanding when they might be an issue for your patient so you can give them a good recommendation, I think is something we have to do.
That's right.
Yep.
Now, having
Yep.
said that, if the patient says, I don't care,
This is the
and
question
I'm not
we
going to do
ask.
that, I want you to fix my teeth because I have destroyed them. I'm going to argue that as dentists, I think we have an obligation to try to help people have teeth that can function well and normally. And so now you make a decision. There are people who would say that I am unethical because now I'm going to go treat their teeth. I would say, we did it for years without knowing about airway. Knowing what I knew now, maybe I can find a place and a size of tooth and a VDO that would allow them to feel better and not destroy their teeth. Tell me why that's a bad thing if I've advised them of
It's
something and
informed
they've said I'm
consent,
not
sir.
going to do it.
It's informed consent,
Thank
Dr.
you.
Wood. You just said it right there. You
Yeah, we had this
advise the
discussion
patient.
just yesterday. We
On
were
the
at
plane,
the
man.
airport coming
That's
back,
it.
and we were just saying, Wes said, well, what if they say no? What if they say no? What if they won't even, or what if you do a pulse ox or a HST or whatever, and they say, I'm not interested. And, we start to
fix
think
my
about
teeth.
this.
I want my teeth
Yeah.
fixed, but I'm not interested.
Now,
And
the
as you
beauty
said-
in that is, I think sometimes what they discover is if you've helped them in that process understand some of the things, they begin to self-recognize.
Yes.
So that I would argue this, with those patients, it would be uncommon for me not to put them through appliance therapy. I need to figure
That's
out,
right.
is there could an appliance be a thing? If I could open vertical to some point, would that be helpful? And if
right.
I could let
You
them
start
be
to
where they're
think about
comfortable,
that.
could that be helpful? And if all of a sudden they're telling me, I'm asking, how you sleeping? Because when we
Yep.
talked before, you weren't sleeping that great, which is kind of one of the reasons. Have you noticed any differences? I think if we do those things, we'll lead many more patients toward the right solutions.
Yeah.
And some of those solutions might honestly just be dental. It'll also mean that we will recognize times when we'll have to look at somebody and go, this is not in your best interest to avoid this. So I'm uncomfortable just doing the dentistry.
Yeah.
Well,
And you
and
all
two,
know you're
you know,
going to
you-
have some of those.
And you made the comment back, I still remember this really well from the occlusion course, as you said, when you're trying to evaluate, when you're trying to move somebody to think about full mouth reconstruction after going through splint therapy, if they get better, that you would say something along the lines of, wouldn't you like if it felt that way all the time?
All the time.
So the beauty in that is what you want to do if you can is you want to bring the patient to a place where you can ask them with their appliance in and with it out, which do you like better? And if they say, I like this better, and it's the appliance, the question that you want to come to the room is, can you make my teeth feel like that?
Yes.
That now means you have a partner. And if you can find a way to bring patients to that place, I'm going to tell you, it doesn't matter what their insurance pays, because that's not their motivation now. Their motivation is to have this. And what I have noticed with most people, and it's not just restricted to dentistry, as soon as they realize there's something they want to have, what do? They do?
They find a way, don't they?
They find a way to get it.
Every single time.
Yeah.
Virtually
And like
every
you
single
say it,
time.
And it
Yeah.
may be that what's really going on is that they're breathing better.
Exactly.
And instead of just biting better, they're
That's right.
breathing better.
Exactly.
And so, but in the end, you get to the same point. It's just that we didn't realize what we were doing for people. We didn't realize that we were helping people in a way that we thought was different, but in the end, the same result. So like you say, with the patients who are not receptive to this idea, in the end, you know enough to know things that may help. Definitely, you're trying not to do harm, but you do what you can.
I'll push our courses a little because Jeff Rouse
Yeah.
brought us some new thinking, and the course on airway, our airway workshop, is actually about trying to figure that out. And in his course, what he does is he's using an appliance that can now become useful actually as a mandibular advancement device to start to figure out, well, if I bring the occlusion forward a little bit, does that help? Can I get you to where you're feeling better? To help you sort of figure out, is there a place where we could put a dentition together that would help? The beauty in that also is, as you pointed out, at some point patients then realize if that's not a solution but they feel better, they go, well, okay, maybe I need to go learn more about this.
Yes.
And they now they're ready to have you send them to the place where they need to be.
Right.
So
And you mentioned, this whole idea of trying to figure out what the patient does. That's what you're trying to do with an articulator, and it really mirrors this idea with the airway. Is we were trying to move more to the same. It's almost in a way that Rouse appliance that he talks about is a way to kind of try to mimic what's happening to them at night when they're collapsed, and you're trying to mimic that and figure out what type of occlusion or what type of appliance or where do they need to be so that you can mimic what's happening, and then you try to recreate that with either
to bring that full circle, because what you're doing is you're adjusting the ultimate articulator to a place that works. In the old days, what we did is we took our articulator and we adjusted occlusions to a place that we thought could work, and then put those in the mouth. Today, there might be a way to say that could work, and then you can take it back to the articulator, mimic it, and recreate what you had.
Exactly.
And that's where things like today, the exciting thing for me is that virtually there's way more possibilities to capture those real movements of people and put them onto that articulator.
So way more easily. Which companies, because we don't have a lot more time, but I do want to know what you think about that. Are there companies, are there ideas throughout different companies that you feel are doing it right, or that
like
really have some exciting technology?
Yeah.
So I'm a bad source for this because I'm still a lurker and a watcher on this. I'm not actively involved in stuff. Kevin's done way more than me on this. I will tell you that I've had a good chance to play with the CEREC articulator in that machine. It's a fully adjustable articulator. The hardest part at this point is figuring out what you should do the settings at, but they're working on that. I think that one of the companies doing some exciting stuff is Sirona. They're doing some neat things with Galileos to make it possible for you to couple it together and take data that you gather, movement data from Galileos. You actually have the patient move, and you gather this data. And that coupled with a CBCT scan, and then with intraoral scans, I mean, you can mimic what somebody can do with, I want to say, a high degree of accuracy with the ultimate accuracy. They did it. There is no middle ground to now reset something else. They created that movement.
It's amazing.
And I think when we can take that and we can verify, through that there is because I know there's been a lot of discussion about, how important or how much CBCT can correlate with airway, and there's been a lot of discussion about that because, of course, you have the patient in a different position oftentimes than what they really are and all that. But it's moving in that direction now where we could get that data. And then, of course, the same thing, we have with facial recognition type of software that comes into that play. I mean, we're getting closer to the virtual patient, aren't we?
Actually, and if you take some photographs, it doesn't look like the virtual patient. It looks like your patient.
Yeah,
because there's software out there now that lets you stitch a photograph to some of the stuff, and then it will move it the way the patient moves. I mean, it's unbelievable.
You're looking
and
at
again, I'm not the expert on this. I just walk around. I was just at the New York dental meeting. I was speaking in New York, and I walked around, and some of the stuff I saw was like, you got to be kidding me. That's amazing stuff that's out there.
So let's kind of bring this home a little bit, because
all right.
I guess I could listen to us talk about this kind of thing all day long.
Yeah.
And I really would love to have you back to talk a little bit more about some little nitty-gritty details that we still have questions about. But from a standpoint of Spear Education and where you guys are at right now and what you're involved with, tell us a little bit about, you spoke to it earlier, about where people can go to learn more about where do they start. Because some of our listeners haven't been involved with Spear at all, but where can they start?
So the first thing I always ask people when they say, what should I do? Excuse me. The first thing I ask people when they ask me that question, and what should I do, is I say, how do you like to learn? And they usually don't know. And I say, well, let me give you an example of two different kind of learners. I'm going to talk about myself and my wife. My wife likes to think about things, understand principles, and then experiment with those principles to see how you apply them. Cheryl should take a seminar before she takes a workshop, which she does. I like to try stuff and get my fingers in and do things, and then try to understand how it applies. So for me, I would take a workshop first, okay? Because now I can sit in the workshop and have reference for all that information, and for me, that process is better. And I hate to cut to something simple, but this is kind of a crazy one because it seems to correlate, is when you get out something, have to put it together, do you read the directions or do you just put it together?
Right.
And then go look at the directions and say, okay, let me look at this. Because that often is a way to talk about it. So I would argue this: if you like to learn by doing things with your hands, facially generated treatment planning is the entry place where we raise all the questions. If you move from that to the next course, which makes sense to me, that's the occlusion course. It's really one giant course. I wish we could do it all at once, but we can't. Okay? In that course, we tie together the functional aspects, and that's where we really spend a lot of time talking about gathering the data that allows you to take what the patient can do to a point where you can begin to understand it and use that information. And for me, those are the entry points. If you want to learn to do those kinds of things and you want to learn about them, I'd say take the occlusion seminar. Because that touches on how we figure out the aesthetics, but usually for people who have a real hot spot for wanting to figure out function, the aesthetics part of it is something they kind of already understand, at least in their own mind, which for me, that means you understand it. I hope you're open to more learning, but if you believe you understand something, here's something I do know. Adults have to identify what they want to learn before they will burn any energy doing it. So when I always ask people, what would you like to learn? And then I can point you in a good direction. I think the occlusion seminar is a great thing if you wonder about articulators and occlusion stuff, because it's going to give you a chance to think about it.
Right.
And then you can point yourself toward what direction makes the most sense for you. If workshops then are good things to follow for you, we would have suggestions for that.
Now there's a way.
Do you think too that now with all we've talked about with airway, that after occlusion, are you telling people that instead of maybe thinking about restorative design, that they should think about airway next? I mean,
So actually, I will tell you
you?
that the occlusion seminar has been kind of rewritten for next year, and it's impossible to talk about occlusion today without talking about airway.
There you go.
So
Because
there
now
will
it's
be a
no
whole
longer-
bunch of airway diagnostics in
Yeah.
there. You have to have it in there.
You have
it's got to
to.
be there.
It's part of our exam now. So
Part of what we do. We also have a
If you-
seminar that is called the Airway Seminar. And that is a lot of time with Jeff to go into way more detail around those diagnostics.
if you want a taste of spear education, and really for me, it's a great resource to go back and listen to some of these instructors, Spear Online, and speak to that.
So Spear Online is a great tool. Pretty much anything that you can find in a workshop or a seminar is covered somewhere in Spear Online. It's courses, if you will, that range anywhere from 10-minute segments all the way up to an hour segments around lots and lots of topics in clinical areas and in practice management areas. If you're not a subscriber and you're interested in that, actually, if you email me, I can forward you to some people who can actually get you a trial if you'd like to try it. You can actually, I think, just go to spear.com
Well, actually, Dr.
and
DeWood,
click. Yes.
let me just kind of interrupt you for just a second, because the Dental Guys has been given a promo code for $20 off a month, normally a price of $189. If you're a
There you
listener
go.
of the Dental Guys and you're listening to it right now, click the link in the description below, and you'll go right to a landing page. It's welcome fans of the Dental Guys, and if you sign up for Spear Online today, enter the promo code TDG, that means the Dental Guys 169, and you're going to get Spear Education Online for $169 a month, normally $189, saving you $240. So right there you go.
Okay, thanks. I didn't even know that. I'm glad. I'm happy that you guys are doing that.
Right.
That's wonderful.
Yeah.
Well, we
it-
appreciate
it's-
Spear Education hooking
Thanks.
our listeners up with that.
Yeah,
so that's
thanks,
awesome.
thanks to Spear Education for that, and Dr. DeWood, we really appreciate you being with
Thank
us
you
today,
so much.
because what you have challenged us personally, and I think you've challenged our listeners in a similar way to keep following that knowledge and figuring out what they don't know and digging into it. And what we're all about on this show is trying to be research-based, evidence-based, but to also, like you had kind of alluded to, find out what you don't know. Try to ask those questions, asking
Cool.
good questions of people that are hopefully have had more experience and the smartest guys in the room. That's what we're looking for. And we feel like this is a great way for somebody who's wondering about a lot of these issues to maybe dust off the old articulator and figure out what they don't know. And that certainly was something that both Wes and I were challenged by when we got to take your courses. So we encourage you to go and check out Spear Education, check out what Dr. DeWood has to offer. And Dr. DeWood, thank you again for being with us today.
Thank you so much, Dr. DeWood.
It was my great pleasure. Thanks for the opportunity. Thanks you guys for doing what you're doing, because just getting this stuff out there, it gives people an opportunity to maybe get past, wow, that's something I wondered about, and go do something about it. So thanks for doing what you do. I appreciate it.
Yeah, absolutely.
And thanks for having me.
Absolutely.
Yeah, and if you're
Absolutely.
listening today to our show and you want to go give us some feedback, especially after such an awesome show like this, go to iTunes, give us a 5-star review, check us out on Facebook, give us a review, leave us comments. We would love to hear your
Send us
take
a
on this
message.
show.
Yep.
Yeah, send us a message. Let us know what you thought about this. If you want more information from what Spear Education offers, of course, it's very simple, speareducation.com. But we'd love to have you give us feedback specifically on what we're doing well, what you'd like to see on our shows coming up. We got some very exciting stuff coming up with Spear in the next few months that we'll be filling you in on as we go. But it's been another wonderful show with a great guest. And Wes and I are going to continue to bring you this quality of content as every time if we can. Thanks for being a loyal listener. We are the Dental Guys.